Today, we're going to break down a landmark study published in the British Medical Journal by Cai and his colleagues. They looked at a class of drugs called GLP-1 receptor agonists and their potential connection to the risk of substance use disorders.
And this really gets to the heart of it. The study asks a pretty profound question. Could these really popular drugs, the ones we use for diabetes and weight loss, also be a way to treat addiction? That's the central mystery they set out to solve.
So, to really appreciate what this study accomplished, we first need to understand the context. Let's talk about what we knew before this research came along and the knowledge gap it was trying to fill. This idea didn't just come out of thin air. There were already some clues. Animal studies had suggested that these GLP-1 drugs could make substances less rewarding by acting on the brain's pleasure circuits. And a few human studies hinted at a lower risk for alcohol, tobacco, and even cannabis use disorders. But the evidence was kind of patchy, especially for other substances. And the big missing piece? Large-scale studies looking at actual clinical outcomes. So, to fill that major gap, the researchers needed a really robust and powerful study design. Let's get into how they actually did this. And the first thing you need to know is the sheer scale of this thing. The analysis pulled data from over 600,000 U.S. veterans with type 2 diabetes. That size gives the findings some serious statistical weight. The team used a really sophisticated method called target trial emulation. Essentially, it's a way to use real-world data to mimic a massive clinical trial. They compared people who were new users of the GLP-1 drugs against people who were new users of a different class of diabetes drugs called SGLT2 inhibitors. Now, this comparison is what makes the study design so brilliant. See, the SGLT2 inhibitors work on diabetes pretty much just in the kidney. GLP-1 agonists, on the other hand, are known to cross the blood-brain barrier and actually influence the brain's reward system. By comparing these two, the researchers could isolate the specific brain-related effects of the GLP-1s, separating them from just the general benefits of treating diabetes. So with that clever setup, the study was able to tackle two very distinct and very important questions. The first they called Protocol 1, and it was all about prevention. Basically, could these drugs stop a new substance use disorder from ever developing? Then, Protocol 2 looked at harm reduction. For people who already had a substance use disorder, could the drugs reduce the risk of really bad outcomes? Okay, let's get to the good part, the findings. We'll start with that first question from Protocol 1. What did they find out about preventing new cases of substance use disorder? Now, this table really is the core of the prevention results. The number to focus on is the hazard ratio. All you need to know is that a number less than 1 suggests a reduced risk. And just look, compared to the other diabetes drug, patients on GLP-1s had a significantly lower risk of developing a new use disorder for pretty much everything: alcohol, cannabis, cocaine, nicotine, and opioids. It's incredibly consistent across the board. So, what does that mean in plain English? Well, those hazard ratios translate to a 14 to 25% lower risk of developing a new substance use disorder. That suggests a really broad preventative effect across a whole range of different substances. Okay, so that's prevention, but what about that second question? What did the study find for patients who already had a substance use disorder? This brings us to the harm reduction results. And the results here were, if anything, even more dramatic. In folks with a pre-existing disorder, taking a GLP-1 drug was associated with a big drop in severe outcomes. And I want you to look at that last bar, a hazard ratio of 0.50. That's a 50% lower risk of substance-related death. I mean, that is just a profound finding. And there's another critical piece of data here. There have been some safety questions raised about this class of drugs in the past. Well, what's so noteworthy is that this study found a 25% reduced risk of suicidal ideation or attempts. That's a huge deal, especially in this high-risk population, and it actually lines up with other recent studies suggesting a potential protective effect. So we've looked at prevention, we've looked at harm reduction. What does it all mean when you put it together? Let's talk about this study's conclusions and what this could mean for clinical practice. Now, of course, no single study is perfect, and good science is always honest about its limits. The strengths here are obvious: the enormous size, that sophisticated design, and the really smart choice of a comparator drug. The main limitations? Well, the study was done in the VA system, which means the population was mostly older, male, and white. So we have to be careful about generalizing. And like with any observational study, you can't completely rule out some other unmeasured factor influencing the results. The authors themselves did a great job of summing it all up. They gave 3 key take-home messages. First, a broad preventative effect. Second, significant harm reduction. And third, a strong clinical implication that these drugs might just have dual anti-addictive properties, meaning they can both prevent and treat. This quote directly from the paper's abstract really captures the essence of it. The data strongly suggests these drugs could have a role in both preventing and treating substance use disorders, and because of that, it absolutely warrants more research. Which, of course, leads us to the final and most important question. Where do we go from here? An observational study, even one as massive and well-designed as this, is what scientists call hypothesis generating. It sends up a huge, bright flare, a powerful signal that we're onto something. But it isn't the final word. The definitive next step, the gold standard of medical evidence, is to run large-scale randomized clinical trials. And this study provides a very clear mandate to get that research started.